Hi everyone. Welcome to the Aidin webinar on COVID-19 and the impact on the post-acute placements. We are so excited that you're here today. My name is Akanksha Karwar, and I am one of the senior directors here at Aidin. And I've been working in healthcare for about 10 years. And for those of you who don't know what Aidin is, Aidin's actually a referral management tool marketplace that is used by many institutions across the country. So we have access to a lot of data. And I want to kind of tell you the story of how this call came to be, what happened, and how we got here before we dive straight into the questions. So for that, I'm going to start sharing my screen. This all started I would say a few months ago, during the pandemic. I was seeing headlines after headlines after headlines on the impact of COVID-19 on the post-acute placements. And this is just a few examples. We were seeing, of course, the press that was generated around the nursing home outbreaks, as well as, the impact on the home health market. What I've seen more and more coming out is this sort of tension or a story of this tension between hospitals and post-acute providers, as well as patients not knowing or being lost in the midst of all of this bureaucracy. And so when I saw all of this, these headlines, I realized, we have a lot of data that we have access to. So I wanted to see, what's actually the truth? What are we seeing within the data? So we took a look at some of our numbers, and essentially what we saw is that we took basically placements of our hospitals, what they did, what the trends looked like in 2019, and what did the trends look like in 2020. And this may not surprise you, but there was an 18.5% reduction or decrease in the number of patients that were actually going to skilled nursing facilities. And I thought there would be, like almost correlated, but there was 14% increase in placements for patients that were going to home health. And this wasn't just concentrated in certain geographies or in urban areas. This was across the board. We looked, even a little bit deeper. When pretty much across the board, what you're seeing is there was a decline in skilled nursing facility placements and an increase in home health placements. Some of that warranted, some of that we can explain. But when I saw this, it left me with more questions. And I was like, I need to understand, one, what is the full scope of these changes? Yes, I see some trends in terms of where the placements are going, but more importantly, there's a whole structural component that changes. You have more telemedicine, liaisons aren't allowed in hospitals. How are you taking care of readmissions if patients are going more to home health? Has that increased? So what is the full scope of these changes? And then are these changes here to stay? Do we expect, after we're out of the pandemic fully, will we go back to functioning the way we did? Or are there certain components of these changes that are going to carry forward with us? And of course, these changes, taking telemedicine as an example, has a huge impact on the entire healthcare ecosystem. There's a technology impact, there's payment regulations impact, and then again, how do we prepare to, go forward? These were the 4 questions that I just naturally came to me when I was looking at the data. And so what we decided was, why not get the best and the experts that are within the ecosystem together to help answer some of these questions. So I'm going to go ahead and switch to asking all of the panelists to introduce themselves. Lena, actually, why don't you start? Lena, you may be on mute.
Good afternoon, everybody. My name is Lena Patel. I am a registered nurse, and I am representing Accent Care UCLA Health.
Welcome. Paul.
Good afternoon. Thank you all for being here. My name is Paul Arias. I'm the Assistant Vice President for Care Coordination for Loma Linda University Medical Center in California.
Excited to have you, Paul. Stephen, why don't you go next?
Good afternoon, and Akanksha, thanks for having me. My name is Steve Blau, and I am the Senior Director for Care Management and Transitional Care with Luminous Health in Annapolis, Maryland.
Excited you're here. Kirk.
Hi, my name is Kirk Watson. I am Vice President of Business Development for Barlow Respiratory Hospital, a long-term acute care hospital in Los Angeles.
Welcome. Jessica.
Hello, my name is Jessica Tonneson. I'm a licensed nursing home administrator, and I'm also a Regional Director of Business Development for Laurel Healthcare Company. We're a skilled nursing and rehab company operating in 5 states.
And Tara.
Good afternoon, everyone. I'm Tara Hoare. I am a geriatrician and palliative medicine physician at Vanderbilt University and serve as the Chief Medical Advisor for Vanderbilt Home Care Services and work in the skilled nursing facility setting.
Awesome. I'm so excited you guys have agreed to join us. Before we get into questions, I just want to do a quick housekeeping with everybody else who's here. So everyone else, if you're having technical difficulties or if you can't hear, my coworkers will put our chat in the chat box. They'll put our phone number and you can call that phone number and get your technical help. We're going to ask if you have any questions. If you can also just keep typing them in the chat box. There's a section towards the end where it's open audience questions, and we'll be collating that data and asking that. And then the last piece is we have some polls. So as we're talking, there's going to be some polls that will launch and will help dictate some of the conversation. So just engage with the polls. Awesome. So let's get started. Like I said before, for me, it was the trends. All of these changes are happening. What are these changes in terms of shifts of where the patients are going, how we're taking care of patients now, and how are we monitoring and managing these outcomes? But the first kind of piece that comes here is what are these trends? And Paul, maybe if you want to share your thoughts.
Sure. Like Akanksha mentioned, we've been tracking these trends as well since last year. It came to light on me by one of my physicians asking me about the percentage of our patients going to home. He was more worried about U.S. News and World Report in the percentage of patients just going home. So I started looking at the patients going to home health and going to SNF as well, and the impact of patients going home. And I saw this trend started in January 2019. And then obviously with COVID, we saw this expansion too. So I started reaching out to some of my colleagues across the United States and asking them, what are you seeing? And are you seeing a similar trend? And then I started looking at our own data to see what the impact really was. And where we used to be almost even 12, 13% going to SNF, 14, 12, 13, 14% going to home health. By the middle of 2019, that had started shifting to about 16, 17% going to home health and 10% going to SNF. And then by this year, it's 20% going to home health and 6, 7% going to SNF. But then I dug a little deeper and looked at, well, what are the payer sources? And a lot of this was being driven by managed care. Here in California, we have a lot of independent practice associations that are driven by physician-led insurances. So they're what we call IPAs. They're physician-owned capitated plans. And they're delegated risk organizations from a larger organization. So we love in California to name things different. So our Medicaid plans are called Medi-Cal. And so they take on full risk, capitated like they used to be back in the 90s. And so they own the total dollars and the total cost of care for these patients, similar like a bundle payment care improvement. So it really, it behooves them to be as strategic as they can in the spend of their dollars. So if it's a little less expensive and they feel like you can still get the quality outcome by sending somebody to home health instead of skilled nursing, they're going to do that. Couple that now with COVID and the patients and the families not wanting to go into SNF, we're seeing a large percentage. This month, we had 19.5% in February, I should say, go into home health and 5% go into skilled nursing. So one of my fears is we're going to start losing beds in the community. Skilled nursing is not going to be able to keep the doors open. And if we have a rebound back, that's going to make a huge difference in where can we send our patients. And then the quality of what can our home health agencies do in the long term too. That is an effect that I'm really, really worried about. Can these patients be sustained with the care that we truly need in a home health setting as opposed to a skilled nursing setting? So
that's a $1 million question. Kirk, are you seeing some, so I know your patient population is a little different, but you're also in California. Are you seeing similar trends and sort of why do you think if there is a shift, why it's happening?
So as you mentioned, we're in LTAC and our patient population is a little different across the board. And so our discharge dispositions are a little different. What Paul described isn't affecting us as greatly. In fact, our discharge dispositions are pretty stable, but we are seeing more and more managed care. We are seeing more and more influence from IPAs, and the decision-making process is a bit different than it has been historically for us. It makes moving patients a lot more difficult and a lot more complicated, on top of all the medical issues that we all have to deal with. And that difficulty has been exacerbated during the pandemic for a variety of reasons.
So you said the decision-making has changed. Tara, is that something that you are witnessing, seeing, one, within your market and also within your practice as a physician?
Yeah. Yes, absolutely. I think patients and families are very actively engaged in the decision-making process currently when it comes to post-acute care. I think the reasons for that, understandably, have been concerns from patients and families about infection risk by being in an institution. And so we've seen patients and families even still making phone calls to facilities upon having a referral place to ask questions about what are the infection prevention measures that are incorporated at that facility before they will be comfortable allowing a loved one to go there. And then the quarantine period has also, and visitation restrictions has been a huge barrier for patients and families wanting to go to a post-acute setting. We've seen a little bit more as here locally, they lifted some of the restrictions and allowed, as we've increased vaccination rates, allowed for more visitors to be in the facilities. We've seen a little bit of a rebound in the percent of patients who are choosing to go to a skilled nursing facility. In addition, I think another thing that has come about over the past year is that as we have seen COVID patients require a period in which they remain in the hospital before they could be accepted to a post-acute facility because of the infectious period, we've seen the hospital become more creative in getting increased involvement by physical and occupational therapy in the hospital setting, and have been able to take patients who have initially been recommended by therapy to go to a post-acute facility and do their rehab in the hospital setting and ultimately change their discharge disposition to home. And so I think this has affected our incorporation of the therapy services within the hospital setting. And as we've seen more patients choose to go home with home health and adjustments in home health practices to increase involvement with patients, I think that we've also, in a way, educated providers about home health. And so we've had providers really looking more towards sending patients home and increasing their own referral practices.
Stephen, I know, being on the East Coast, some of those California specific things that Paul and Kirk mentioned might not be the same as what you're experiencing, but what has been your experience? Has the disposition making changed, and what are the shifts that you're witnessing?
Similar to what Paul and Kirk described, with an increase to discharges to community, and for very similar reasons that Tara described. Fear is a great motivator, and the unknown of the nursing homes were driving families and patients to make choices to recover in the home. And the other things she described with restricted access were the initial governors and the changing protocols, and we were all in our business getting different information around guidelines. There seems to have been a settling of those. But even with patients recovering at home, the fear has preempted some of the decision making, so that it's not as easy to get people the care and support in the home that we used to be able to provide. People are leery of allowing somebody in their home. We had a patient, we had a medical equipment delivery company call and say, we're at a patient's home, we're on their front step, and they've asked us to drop off the bed on the front porch. They didn't want to allow the company in to set up the bed. And of course, they weren't willing to do that. So they were at an impasse. But on the positive side, you earlier talked about telehealth, and we've seen tremendous capabilities for in-home services, the evolution of remote patient monitoring and biometric feedback, and our ability to do virtual rounds and virtual visits. It's changing the landscape. So as the capabilities evolve, it allows people to make different choices, and then our jobs change in care coordination to become educators and really to help people sift through what options are available.
And so we've been, hearing from all of you, understand definitely what the impact is on the hospital side, and that there's a completely different picture, which I think Jessica and Lena bring to the table. Lena, from your perspective, so have you seen a higher acuity of patients, just given, one, fear being the motivator, disposition, and all the restrictions around quarantining, everything everyone talked about? What's been the change that you're witnessing?
So for us at Accent Care UCLA Health, we have a higher acuity of patients to begin with because of the health system that we're affiliated with. So this was actually the norm for us, but COVID was uncharted waters. And as Steve mentioned, we were essentially flying by the seat of our pants. Any changes that were made by the CDC, we went along with it. Changes that were made at UCLA, we incorporated as well. So there was a lot of these trends. We also had an increase in direct admits from the ER. We've always talked about an ER diversion program, but we had a lot more patients going to the ER and then coming straight to home health for monitoring, especially those patients that needed more in-person visits than what the COVID team was able to provide from the hospital. And we also had an increase in IV therapy at home to treat our heart failure patients, because we were treating, of course, COVID patients, but we had a lot of patients with already disease processes that made them frequent flyers, but we did a lot of IV therapy to help diurese them at home because we weren't necessarily sending them to urgent care or the ER. Many times we would have ambulance people saying, no, we're not going to take them to the hospital. They would absolutely come to the home and triage them and say, no, we're not going to take them. So, it put us in a difficult position, but yeah, it was definitely uncharted, but I think that we have a much better grip on it now with everything that's been going on.
And Jessica, your perspective in that, like Paul said, there's an adverse impact potentially to the skilled nursing community, with beds maybe going empty because of all of the reasons that we've talked about. What has been your experience in Ohio?
Yeah, you're absolutely right. Ironically, you brought up the 18% number. That was exactly company-wide, the exact number in all of our data, that we lost 18% of admissions to home. And, across the board, it was ironic when we pulled all those numbers. And so it's right on point. Obviously, we're a business, and you're right, we have to fill beds. That's what we do to stay open. But the acuity of our patients increased dramatically, 25 to 35% across the board in our states that we operate in. And I mean, we know why. It's what every panelist has already said. It was a safer, smarter choice when able for somebody to return home, especially, you have caregivers who are ultimately, when 24/7 care is recommended by the hospital team, if you have somebody at home able to do that, where often you didn't when everyone was not maybe working from home, people were pulling more resources to be able to do that. And home health care was upping their game, right? Like coming out in full force to answer the call. And ultimately, we were all trying to do that. Hospitals, that as the trends shifted through our markets, there were no hospital beds. So like Lena said, we were receiving straight from the ER, and more than ever, and having to be, on our game with answering admission calls using services like Aidin and those referral management systems 24/7, because teams were piecemealing together, right? Like covering for one another. It was, at many points in this pandemic, just like Lena said, we were just thinking on our feet all the time. So yeah, it has been a road, and we know though that we have to still remain a steady partner, and it's keeping folks out of the hospital. So we may not be referring or receiving the volume of new admissions, but our conversion rate was higher than it had ever been. So those referrals that we were receiving, they were acute and they needed us. And we knew that they needed to be placed because there were COVID patients filling hospitals, right? And so we had to be able to receive. So the insurance contracts and those managed care plans, Medicare and all of it, waived their prior authorizations for long, and that was a huge benefit to us, be able to readily accept and keep the hospital beds open for COVID, and then also do whatever we could to reduce a rehospitalization and keep those acute patients in-house. So that presented a whole nother challenge, right?
That brings up, so of course there's an operational component to this. You're innovating, you're in the fly, trying to make sure you're in regulation compliance, make sure you're in compliance with, whatever the state needs, the county needs, what your partners, your other colleagues need. There has to have been, one, a financial impact, and then two, more of an outcomes, like what outcomes have become more important. Stephen and Paul, maybe from your perspective, what's shifted financially, and because of the shift in finances, which outcomes have become more important for you to track?
Steve, you want to go first?
Well, we're on the backside, most of us, of this pandemic. As we were going through it, clearly we saw prolonged hospitalization with people affected by the pandemic, and with the restricted access to not just SNFs, but to home care access and to community programs as everything was shutting down. We saw longer and longer lengths of stay, and or people avoiding getting the care that they needed. And so they were putting off maybe what, this term elective procedure, I think we've now understood as a misnomer, or can be confused with maybe not that important. But people have been putting off, and now they're coming in for care. One of the things that I've seen shift with regard to the trend is clearly as it being in the business of coordinating care and presenting options, is really educating patients and families and care providers about what is possible now. And our landscape, as we've been talking on this call, has shifted. and we can do more things in the community than we were able to do before. We've tested our capabilities to be able to do televisits and communicate. It's really forced us to think different and work more closely with our care partners. So some of this forcing function has actually helped us to evolve in very positive ways.
What about you?
So, yeah, when I look at key performance indicators, what we were tracking before, things that I've added to my scorecard for this year, and things that Aidin can help me with, and you've been helping me add more data to my referral report. And something that I've been working with my physicians quite a lot over the years is, the time to first referral. When are they actually pulling the trigger for my consults, my orders? When are they actually allowing me to make and do that proactive discharge planning? As we saw with especially here in Southern California, oxygen needs, DME needs, delivery, the whole supply chain was affected with COVID. The entire ability to move a patient's throughput and deliver. Steve mentioned about the delivery of that bed. Well, it wasn't just getting through that door, but it was getting a driver ability to actually deliver it. It was getting somebody who is a COVID positive patient in a transport gurney and having a COVID driver. So it was my contracted individual companies, their availability. So everything had to be moved up in the timing. And I have what we call tip sheets here, and we have hours. We tell our physicians, I need 48 hours for this. I need 72 hours for that. Well, we started telling them, well, we need 96 hours for this. We need 120 hours for that. And so being able to track that as a key performance indicator and going back to them and say, you're working within this time frame, this is your outcome for that month or for that week, has been really important to us. We're looking at DME right now, and what is that impact to certain units when you put in your time and when that patient gets out the door and when they actually leave. So when you put in that order, how is that impacting throughput? So it is an important measure for us. 6 months ago, that first time to first referral was on day 3. We've got it now down to 1.6. So it's making a difference, and our length of stay, which had climbed during the COVID, is starting to come back down. So having the ability to get that data out and show it on a scorecard to my physicians and how they actually practice is helping. What didn't help is that they were using a consult, which we saw over 12,000 consults in a 6-month period. We have changed how IS handles that within Epic. So that helped too, because we were tracking it. So leveraging your EMR is very important too.
Tara, I know you will have something to say about that, but before, I want to just make sure also, Kirk, so here's like supply chain disruption that's happening. Here is regulation changes that are happening for you, although your shifts didn't really happen and your trends stayed the same. Did you feel the impact of the supply chain disruption in the LTAC community and as well as with the government regulations? What are your outcomes now that become more important?
Absolutely. So, the LTAC business is pretty simple. We get patients in the door, we get the patients better, and we send them out the door. And the pandemic hit us in all three areas. It was much more difficult to get patients in the door for a variety of reasons that have to do with effects on the short-term acute care hospitals, as well as our own ability to assess patients, to deal with families and help them make decisions. Transportation was difficult, on and on and on. Getting patients out the door was obviously difficult because of all the effects post-acute providers here today have discussed. And that meant patients stayed longer. And as the clinical folks always remind me, the longer patients stay, the more things happen to them. There was a period of time where we couldn't get a patient in the door or out the door for weeks, literally weeks. And that's not good, obviously, for the business. It's not good for the patients, and the entire system kind of came to a halt for a while. And obviously, with everybody working together to redesign the care management system and the way things worked, we got through it. But there are 1,001 reasons for that, from, you know, like Paul said, not having drivers, not having, you know, people to deliver the supplies we needed to have delivered, not being able to get good information about what was going on with patients and their families and what their home life was like, because we couldn't communicate with them because they weren't in our building. We were trying to, you know, email and communicate electronically with families that maybe didn't have that ability. A myriad of problems that were unanticipated that are starting to resolve, you know, through the hard work of a lot of people, and also the improvement in the numbers of COVID cases. So it's hard to say what the future will hold, whether the changes that we've made will be necessary and will be maintained. I will say that having Aidin helped. It made all of those decisions and all of those steps that we had to go through easier for our folks. But even with Aidin and even with all the resources we have, things just came to a stop for a good long time.
Absolutely. And so, you know, with all of the sort of pain points and the challenges and the shifts and the trends that we've talked about so much, I know you all were forced to innovate. Innovation had to come. And I know, Tara, you've done some really cool and neat things with the COVID to Home program. Can you share with us what that was, how it came about, and what's the future of that?
Absolutely. So what we did here at Vanderbilt is, you know, we recognized as soon as COVID started and we saw things in Washington and New York ramping up, we identified the need in the Nashville area to have a formal process for which we looked at patients within the Vanderbilt community and paired them to the appropriate services at any time throughout the course of their COVID illness. And so we created a way to risk stratify patients based on severity of illness and risk factors for progression of disease. And one of the things that we created was what we call COVID to Home, which is an enhanced home health or a modified hospital at home program for COVID patients. And we were able to put this together within a few days. We've taken care of a little over 500 patients to date over the year that this has been real. And I think what we have done here is something that we have seen done is that people have identified this need in order to address capacity constraints in the hospital to really enhance services within the home setting. And so we've been able to do that by incorporating technology to our advantage. And I think what has happened is it's caused us to take a critical look at what do we actually need to be able to care for someone. And so the advent of telemedicine as a robust platform to connect with patients has been wonderful. It has also, you know, made us say, in order to have this telemedicine visit, what can we give the patient to make this an even better way of assessing them? And I think what we've done and what many hospital systems have done is use simple technology like a pulse oximeter and giving these to patients either from the emergency department or upon hospital discharge to allow us to better monitor their respiratory status. And then using simple technology like pulse oximeters and thermometers, blood pressure cuffs, has caused us to say, well, how can we do even more? And really start to look at remote patient monitoring devices to enhance the care that we provide in the home and really be able to take patients with illnesses, not just COVID, but other chronic diseases, and say, how can we improve the transitions of care from the hospital setting and also help to improve chronic disease management and keep people at home and out of the hospital. And not only have people been more creative with using this technology, I've also seen a lot of advancement in the technology companies as well. And so a lot of devices we looked at here at Vanderbilt and had spoken to vendors about, before COVID, they have given feedback through the pandemic to enhance their hardware and software capabilities to really do wonderful things with that. And you asked what we plan to do with this in the future. I think one thing that it has done is really showed the hospital system as a whole the value of home-based care. And so we are in the process of building our formal hospital at home program to be able to care for patients with a broad range of diagnoses and not just COVID.
Wow. I think I can speak on behalf of everyone here. If you're publishing papers and outcomes, we all want a subscription to that. Lena, on your, so that it makes sense, innovations happening on the hospital front. What has been the innovation for within your realm of care, and what sort of technologies?
So one of the things that we did was we had liaisons at the bedside as much as we could, except for when the hospital had to completely shut down all visitors. But we were able to use iPads to communicate with patients, go over with them what safety measures our staff are taking, what safety measures we're going to take in their home, and then implement them, because we needed to reassure the patients a lot, families a lot. We were very successful that we didn't have transmission from staff to patients and vice versa. But it was a lot of education, and as the CDC made changes, we were on par with what was happening in the hospital, and we were able to translate that into the home environment. So for our patients, we had a lot of consistency, and we all had the same message. We incorporated quite a bit of telemonitoring. So to Dr. Hoare's point, we did use telemonitoring for a lot of the chronic diseases. But with COVID, it's brought it right to the forefront a lot more. And patients have become actually more accepting because a lot of the doctors are doing video conferencing. And so what we've noticed is that when we see the slightest change in a condition, and early detection, we're able to get a hold of the physicians right away and start implementing a plan for these patients. So we don't get to the point where they actually need to go to the emergency room, because we knew we would have everyday reports on what the census was in the ER, what was happening in the ICUs. And so we knew that as a post-acute partner, we needed to do everything to get patients out of the hospital. And so we had that crunch as well. We developed COVID teams, and we had to do that rather fast. And so we had specialized nurses and therapists specifically for COVID. Many challenges were patients who were on service didn't want services. And so there was always the concern of their condition exacerbating. And then what we were able to do with the hospital, the care coordination team, is when we knew that there was a patient that truly needed SNF placement, but either the SNF was closed or they had an outbreak and there really was no place to put the patient, we met at the bedside, so to speak, and really develop a plan to say these are the needs, and whether it was giving equipment, whether it was working with caring needs, really working out individual plans for these patients so we could get them home. A lot of phone calls, a lot of points. We do a lot of enhanced home health. So we do the Friday tuck-in calls, and and then we also have something called Cinzy, which is the virtual video visits to complement the telemonitoring also. So that was another modality that we did quite a bit of in the home environment.
And Jessica, is that pretty kind of similar to what you guys have adopted, given the fact that I know liaisons were a big part, of the SNF community?
Yes, it's exactly on par with the rest. We do have liaisons in all of our markets, and yes, they remained consistently connected via phone and of course Aidin and systems like that. But it's never the same as the in-person connection at bedside. I mean, um, similarly to the telehealth became something that we integrated in all of our facilities at the end of, it was fall of 2019. So coincidentally, it was perfect timing. Didn't know it would be, but our medical director team integrated telemedicine connectivity that really completely changed what we were doing. We also integrated having our nurse practitioner with that team in the building 5 days a week. And telehealth was always available. So, and that was our ultimate goal, is to reduce the readmissions for anyone at the time. And certainly it always is, but it never was more important. With our partners in the community, those home cares and those other post-acute providers, it's never been more important to have those relationships. And for us, we were, many of our facilities, COVID positive facilities, we had a lot of assisted livings. I mean, there's a whole senior living community, assisted livings, ILs, that we were connected with. We placed at one time during kind of the height of everything, over 100 patients just locally in my Columbus, Ohio market, right in our facilities, avoiding hospitalization altogether. So we admitted direct from assisted living. Those kind of coordinations, lots of phone calls, as Leah said, that was, you know, we let our home or our hospital partners know what we were doing, because like I said, regardless of that reduction in admissions, we're still their partner. And I always will say that there's always a need for skilled nursing. I'm so glad that, you know, I always say too, nobody ever wants to go to a skilled nursing facility, right? It's a hard, like that's a hard place in the continuum of care to accept. And really, families and patients want that personal connection. That was our bread and butter, being able to come in the door. This is your home for a period of time. For many people, it's your home long term. That connectivity with our staff, virtual tours, FaceTime, Zoom calls, all of it. We immediately set up family councils, family Zoom councils every single week. Families had no idea what was going on. They couldn't even keep up with all the state regulations and changes and visitation and how many COVID positive staff we had and patients we had. And so we got face to face with families. We still do those. So these kind of technologies, these kinds of ways to connect have become, I think, and will become a continual, like, new way of connecting with new generations, right? Families are in all different scopes and sizes. And so we've integrated things like that to make it much easier to have that personal connection and give the support where needed.
Fantastic.
I just want to make one more point, which is something that none of us, I think, ever thought that we would have to deal with. And it was the shortage of PPE right from the beginning. And in the Los Angeles community, many of the smaller home health agencies had a very hard time securing PPE. And when we're speaking with the hospital on a daily basis, we are actually talking about the amount of PPE we have and what we can accommodate also. And so that was something, we had executive leadership contacting supply vendors worldwide to try to get PPE because that bottlenecked in the hospital, because they had patients that needed to go home, but agencies couldn't take the patients because they didn't have the proper equipment that they needed to protect the staff.
I'm seeing a lot of your amazing comments, also spurring a lot of questions from the audience. I'm going to shift gears a little bit. Russ, I've added Russ, our CEO, as one of our panelists as well. And so the first question that we have actually is for Kirk and Jessica. Do you think, if you're one, do you think your liaisons are going to be allowed back into the hospital? And if they're not, what's the future? What do you anticipate happening? Maybe Kirk, if you can start us off.
Sure. So we have liaisons, obviously, that used to go to other hospitals. We also have liaisons from skilled nursing facilities coming to that used to come to our buildings prior to COVID. I'm not sure about the short-term acute care hospitals and what their rules will be. We're anticipating access, if it is ever returned, will be much more limited than it used to be. And I know on our end, we're talking about not providing physical access to liaisons anytime in the near future. Fortunately for us, on both ends of the equation, a number of the facilities we work with most frequently use Aidin. We use Aidin now, obviously, for the post-acute providers we refer to. That helps. It's not a complete, obviously, a complete fix for the solution, for the problem. And I quite honestly, I don't know what we do. I don't know what it will look like in 6 months or a year. It's concerning. It's concerning.
Is that the same policy that you think Luminous Health will be following in terms of allowing liaisons coming on site?
So in a post-pandemic normalized environment, I think we have to ask ourselves what's the need and what purpose do liaisons serve? We've proven that referral management can be satisfied without the liaisons in the building. For hospitals that don't have an electronic referral system, it was probably a little bit harder, more labor intensive. With the system like Aidin that handles the referrals, it can actually be a tremendous aid and actually potentially produce faster turnaround times and a reduction of what some of us in the industry know as cherry picking, because a system like Aidin really sets a time frame and an expiration period for the referral. So it really rewards facilities that are fast to respond. But I do see at some point a return of liaisons, but with a modified role to provide that safety net, to provide that patient care experience and supporting the care transition. And liaisons really can help to identify potential gaps in that care transition experience so that you don't have that unexpected return to the hospital within a short window of time because something was missed. So there is value. We just have to think about what's the role and what's the need.
Jessica, you're on the other side. What are you planning for the future? And then, actually start there.
Yeah, I agree with what Steve just said. On really acute chronic interesting cases, right, where like we have somebody to place that maybe has been denied at multiple post-acute providers have denied. Perhaps it's a very complex situation, maybe some IVDU. We are very aggressive as a company in the way we will look at every referral and really take the time to comb through all the intricacies of what might be what might be there and a challenge for a facility. So because we have such a big market and liaisons that cover a lot of ground and territory, they're able to get in with those complex cases. And that's what we've been doing in the system that we use locally, the university system that uses Aidin with us. We can kind of message in on those case-by-case basis. There have been allowances for our liaisons to be able to go and be bedside, but only as it's opened up more. I mean, these are recent changes. So yeah, just looking at new ways to utilize them. I think they're valuable, and but certainly we haven't grown with our liaisons, and we have what we have now, and we're just kind of looking at the future as to how we're going to do that.
And so I'm seeing
yeah. Just let me make a comment with this. So with our network providers, one thing that I have done is, in lieu of having liaisons here, is to give them access to our EMR. We send the referral, and because we're an Epic shop, we can do what's called CareLink, and that takes place of so many of those things. The one liaison which we really want back in here is our liaisons for hospice. because that does make a difference when they can come in and speak to the families. Although we have found a way to use electronic and telehealth type methods, there's still that connection to the family for hospice, the compassionate care component. But having an EMR for our skilled nursing, for our LTAC, for acute rehab, I mean, that right there, I think satisfies a lot of the information that our liaisons used to come in and look at, the medical record, so it changed with the times. Yeah.
Paul, actually, continue. If the one question that was submitted was, given the strain on resources across all levels of care, how can a tool like Aidin improve access and communications for the folks that are involved?
Well, I think that's it. How much information can we load up and provide through there? So using the EMR to load up the information that's necessary, I think asking each one of our providers what's the packet that they truly need to make a decision and a timely decision, loading that out for EMR, and then what's ever missing, and that's why I do it, is all right, well, here's an access through CareLink if you need something, if we weren't timely. If I sent you a referral 5 days ago, instead of having to resend something, well, here it is, right? So I don't have to have my CMA or somebody, my case manager, social worker, resend something. You can send me a message in Aidin and say, hey, or I couldn't find it in CareLink. Can you send it? I already looked, right? So it's an open communication tool, but there's a backup. And for those who can't do that connectivity, that's where Aidin really comes in to be able to load it up and send it. So, yeah.
Your point around, hospice, and there's a different population of patients that's coming rise, and maybe Tara, if you can shed some light on this. Someone submitted, since the beginning of the pandemic, we've seen a rise in the use of antipsychotics to help patients cope with like stress, anxiety, depression. Are there any suggestions on how to better manage this rise or different effective approaches?
Yeah, well, I think in a geriatric population, whenever we see behavioral issues or mood changes, I think non-pharmacologic interventions are the mainstay of primary management before we look at pharmacologic interventions. And I think that has been something that unfortunately has suffered throughout the pandemic within post-acute facilities because of staffing shortages. So first and foremost, there's the isolation from families. And a lot of times families are the most skilled in knowing patients and knowing how to respond to different behaviors. In addition, we've seen that at any given time, a lot of our facilities have had staffing shortages. So now you have the same number, in an ideal setting, it started with the same number of staff workers, but they no longer have any family members who are present to help with things like feeding and dressing and transferring. And so they're doing it on their own. But then we had staff members who were leaving or were getting sick themselves. And so we were functioning with any individual taking care of a greater number of patients than was standard prior to the pandemic. And so those non-pharmacologic interventions with, talking someone down and redirection really suffered. And I think that contributed to the use of increased antipsychotics and antidepressants, as well as families, we're starting to pick up on increase in sort of withdrawing, increase in weight loss because of isolation during this period. And so I'm optimistic that as some of the staffing shortages have eased slightly over the last month or so, and then as visitation increases, that some of the pharmacologic interventions can decrease as well. And then I did also just want to mention, there's been a couple of people who have mentioned hospice over this time period. And I think another thing just to add that one positive to come from this, this is something very much of interest to me as a palliative medicine physician, but I think that one thing that has been done, particularly in our skilled nursing facility setting over the course of the pandemic, is that our providers and the nurses are becoming much more skilled in addressing goals of care and advanced care planning, with patients. And so, discussing that because of the pandemic, because of the possibility of having COVID, let's discuss your goals of care and let's know before you get sick what you would want to do in this setting. And I think that has been, if we need to look for any of the positives that have come from a very difficult time, I think that's one thing that has gone well.
Love that. I love that. We're running against time. I have one last question, and this is for everybody. If you could make an ask for your of your partners, so your hospital, what would be your ask of skilled nursing facilities, hospitals, etc.? What is that ask? What do you need from your partners in this time? Let's try to keep it brief. Steve, why don't you start?
It's not just of the skilled nursing, it's the home care, it's the outpatient and ambulatory setting. We teach patients how to interact with us by making it easy for them to do the right thing. And so as we're putting our heads together and designing our care of the future, how do we create a frictionless environment so that it makes sense to them, we're answering their question and it's patient focused, and we reduce some of these barriers that make them not want to interact with us and choose their own path, which is what they've been doing to this point. So, yeah.
Lena.
I don't know if that answered your question, but that was the last thing I wanted to say. And we didn't answer Dr. Hirsch's question. And he's one of the main guys I think we've all learned from over the years. I'm wondering if somebody could answer his question before we get off. He's taught us a lot.
Dr. Hirsch's questions actually for Jessica. Are your facilities still honoring the 3-day inpatient stay SNF waiver, accepting all Medicare patients with skilled needs?
Yes, that is still in place. Most every other waiver is not from insurance companies, but yes, the Medicare 3-day waiver still is.
Thank you, Steve. Don't know how I missed that. Okay.
Awesome. To answer your question.
Really glad it is.
Transparency and timely communication. I think we as an industry, we get siloed. We have our own agendas, and I understand our business models do that to us. What I always tell my network partners is, I need you, you need me. We need to keep each other afloat because it's all about the patient. We have to find and strike a balance of healthcare finance within our industry to keep each other open. And that's why I mentioned earlier, I worry about my SNFs and the number of patients we're sending them to. When I hear Jessica mention she's down 18%, that scares me to death because I need those beds. If I bounce back, I'm going to need those beds. I have to be able to strike a balance. But if we're not transparent with each other about what those needs are and how do we fix that, then at some point I'm going to be left with a lot of patients in the hospital with nowhere to put them. So we have to be transparent in our communication, but we have to be timely. The other day I finally got a home health agency that I'm working with telling me, I don't make any money off of this insurance, and this is the reason why we turn them down. Finally, I had the truth come out and say, okay, then finally tell me that so we can work together and find us and strike a balance.
Yeah, absolutely.
That's what I needed finally to hear from somebody.
Yeah. Wow.
25 years, I finally heard it.
First time I'm hearing it. Lena, same question to you. What do you need from your partners?
I'm actually going to echo what Paul said, but which is the transparency. But I will say that we are fortunate because we do have transparency and we're very interlocked in regular meetings. And, from our end in home health, we do have to, worry about reimbursement as they do in the hospital as well. But the conversations in the hospital always around patient care, not reimbursement. So it's a very delicate line. And I think that's probably why Paul doesn't hear that as often, but it is really working with the hospitals. Like our liaisons are already at the hospital, and it's something that we've been talking about. So they started about 3 weeks ago, and it's really working with them and having the soft handoff. And, we've been doing this for about 3 years now, and it's really been very, very helpful in that transition of patients and the literature we're giving and the communication from the hospital into the home environment. So we've been very fortunate in that sense with our partner.
Jessica.
We can't say it enough, right? Communication. I think all problems begin and end with it. But when you can have a go-to person at whatever organization you're working with as a partner, we know everyone is so busy and on a different, level of what they can handle and not. But I mean, at Akanksha, the Ohio State University, I have a relationship where if there's a problem with, a specific patient, I get that feedback and I have made myself the go-to person for that. So, I can address the issues. They're looking at their outcomes and their data, who's readmitting, who's not, what the issues are. And then I can really get fine-tuned in there and address it. Because I think a lot of times we, blame is past. We all have metrics, we all have goals, and let's figure out how we can communicate better. A lot of times it's a simple solution. So it's all about knowing in real time what is kind of the issue right now that's most important to my partner. And if I can know your issue and what I can do to help you, then I can know how to handle things on my end better. So,
Tara.
So not to be a broken record, but again, I would say it's definitely communication. And I would say this is my take as a clinician is a little bit different in that I would say transitions of care and handoffs are very important. And we're all doing wonderful things, but whether you can provide excellent care, but if you don't tell the next person who's going to care for that patient what you did, then it's as if you provided horrible care. And so, I think everyone is very siloed right now. And, any way that we can improve communication and handoff from one care setting to the next really benefits patients.
Kirk.
Guess what I'm going to say? Transparency and timely communication. It means everything to obviously not only us, but the patients that we're helping heal. And not to put too fine a point on it, but use the technology that enables timely and transparent communication. Use Aidin. It's made a world of a difference for us and for our patients.
Well, I want to personally thank you guys for, such a fantastic hour. I know I learned a lot. Just the last word from Russ, our CEO. Russ, are you able to get off of mute?
Yes. Hey, everybody. I just a super quick thank you to Lena, to Jessica, to Paul, to Steve, to Dr. Hoare, to Kirk. Thank you all so much for joining. And I also wanted to take a minute just to say thank you to Akanksha. Akanksha, a year ago saw the impact that, this pandemic was going to have on our clients and on our users, and just jumped into action and has been curious and consistent in bringing people together to talk about it ever since. So thank you to Akanksha also for just making this space possible. And of course to everybody who's listening, as I have been this past hour, thanks for all the incredible work you've done this year. Hopefully we can all breathe a little bit and dream into the future together. So we're looking forward to doing that with you all. And thanks again for being here.
And I'll, before just closing, I'll say one last thing is, I think Steve and Paul mentioned this, but everybody on the call, we're a community. Let's work together. Let's use each other to, solve and pathway forward. So I know we'll be sending out bios of all the panelists, and we'll be sharing communication as well as attendee contact information, so we all can, work together. Thank you everyone so much, and have a fantastic weekend.
Thank you for having us.
Thank you.
Thank you, Akanksha.